first speaker today is an ASN counselor. It's Dr. Dan Weiner from Tufts University School of Medicine. Dr. Weiner is a nephrologist at Tufts Medical Center and a professor of medicine at Tufts University. He's the medical director of DCI Boston, the director of dialysis services at Tufts Medical Center, and the director of research in the division of nephrology at Tufts. Nationally, he's the medical director of clinical research for DCI, and his research has focused on cardiovascular and cerebrovascular disease and CKD clinical trials, dialysis, hypertension, decision-making in advanced CKD, and policy. He's currently a member of the ASN Council, with his area of responsibility focused on kidney disease policy. He's previously chaired the ASN Quality Committee, helping to evaluate and interpret impact of quality metrics on kidney care. He was the inaugural editor-in-chief of the National Kidney Foundation Journal of Kidney Medicine, co-editor-in-chief of the NKF Primer on kidney diseases. And I know I have learned a lot from Dan just from being with him on the quality committee. So I think we're in for a treat. Thank you, Dan.
Thank you so much for the very kind introduction. I started this off with the cardinal Zoom error of not unmuting. And so I think I was given the relatively easy topic of trying to predict what we can expect over the next year in kidney care from the federal government. So without further ado, these are my disclosures. There's nothing really related to anything that we're going to be discussing today. So I like to start off with this, and hopefully the sound works. This is President Trump.
It's an incredible thing.
This is one of my favorite quotes of all time. And this is him actually giving an executive order in 2019. And this was a very important executive order because it was the executive order on kidney health, or the Advancing American Kidney Health Initiative. And in this, he laid out 3 priorities within kidney care. And the remarkable thing about this executive order is that it's really one of the first, if not the first executive order ever that's focusing on a specific medical condition, medical state. And it was really something that the entire community could get behind. Ignore the numbers, 80% number there, people paid a lot of attention to. It's not important, but just substitute with that with more. And everything here, I think, is something that we can all get behind. I think it's important to remember as we approach 2026, the rest of 2025 and beyond, that this executive order still stands. Which means that we do have something to look back on and refer to where we can emphasize the importance of kidney health from the current precedent. So in making this talk, I really did not know where to begin. So I hear AI is really all the thing right now. So I asked ChatGPT, what should we expect from the federal government for kidney care in 2025? I'll begin this by saying that they said we're going to get expansion of value-based kidney models, increase federal funding for kidney disease research, focus on home dialysis and transplant, data transparency and equity metrics, expanded access to kidney disease education, and policy adjustments tied to drug pricing and Medicare Advantage. So yeah, ChatGPT, not so much, although number 6 is possible here. So we had a little conversation back and forth, and I kind of changed the question a little bit. And I think it came up with more realistic expectations after a bit, where we're going to be seeing rollback of equity-focused programs, a shift towards market-driven models, some deprioritization of preventive public health measures, and a focus on cost savings, not care gaps. And the rest of this talk is going to focus in a little bit on what we can expect in these various different areas going forward. So what I want to begin with is something that made the news. It seems like forever ago, but this was really just in early April, on April 10th, when there was a passback budget that was leaked that really went into detail, modest detail at least, about dramatic cuts across HHS, including reorganization and cuts in the National Institutes of Health. The diagram here actually shows the process. And one thing that I think it's important to realize is that the current administration, because they started in late January, is pretty far behind the 8 ball in terms of where these processes should be. Typically, you'll see a document like this come out in November. So for fiscal year 2026 budgeting, we would have seen a document like this come out in November 2024. Obviously, that was not going to happen with an administration change. And it kind of gives an idea of where we are right now. So where we usually are in February is the step 5, where the president's budget request is submitted to Congress and released publicly. And that hasn't happened yet for these discretionary spending items. I think the thing to remember or to sort of keep track of is that this passback included multiple new agencies and offices in this particular document that's asking for appropriations. So we'll talk about what that means in a second. And I think the other thing to remember is, even though it may not seem like it sometimes, Congress actually has the ability to do what it wants. Congress does control the purse. They haven't necessarily chosen to enforce that power recently, and the executive is responsible for enforcement, but we'll see what happens going forward. And I think that things are not quite as set in stone as they appear to be right now. So what does this all mean? So in May 2nd, the skinny budget was released and talked a little bit about the NIH. And I extracted some quotes here from the foreword on this. The two in black at the top and the bottom state the administration is committed to restoring accountability, public trust, and transparency at NIH. And in the bottom states that the budget proposes to reform NIH and focus NIH research activities in line with the president's commitment to make America healthy again. And you can see in the middle what they're looking at as kind of the motivating factors that they perceive as to why they're generally discouraged with the NIH and why they think that there needs to be significant change in the NIH. And I have the link here at the bottom for where this document is if anyone wants to read this. So what does this mean? Well, in this skinny budget that was proposed, what you can see is that there are pretty dramatic cuts. If we go down to the third line on this, that's the NIH, and looking at a cut from 45.5 billion to 27.5 billion, or an $18 billion cut, or 40% difference from prior spending. This would bring NIH spending down to around 2003 levels, although that's also not too dissimilar from around 2013 levels, as things were relatively flat for a period of time there. There's other fairly dramatic cuts across there, including a 43% cut to CDC, which supports public health efforts, as well as some degree of research. HRSA, AHRQ, and others also would be receiving cuts. And these are pretty dramatic, and they add up to a 26% in discretionary cuts across health and human services. So what do we do with this? Because that's really daunting and pretty intimidating and could be very impactful. And I think we can take a step back because this is what's coming out of the administration. It's not necessarily what's going to happen. And where I think we can actually draw some knowledge and some inspiration from are two documents that came out about a year ago. One of them is from Senator Bill Cassidy, who's a physician, used to be a transplant surgeon, and is the ranking member on the Senate Health Committee. And he put in a document that looks forward and talks about where he sees the NIH in the 21st century. And there's a lot here, and I think anybody who is in the research world would probably be beneficial to read this document, because I think this is closer to what is probably going to happen. In this, he reinforces the value of basic science. He talks about targeted research in priority areas, specifically calling out obesity as a priority areas. He talks about reducing redundancies. So, for example, you don't need to have clinical trial networks in multiple different NIH institutes, but rather you can have NIH-wide clinical trial networks. And he very specifically focuses in on sustaining the U.S. competitive advantage in biomedical research. So keeping the United States actually at the top of this worldwide pyramid. To do this, there's discussions about reforming peer review, supporting the biomedical workforce, and ongoing transparency. So there's a lot here. Overall, especially in the 2025 environment, I think what he wrote in 2024 can be relatively encouraging. As a supporter of research. And again, remembering that the Senate is relatively close. And we'll talk a little bit more about that in a second. The other document is actually from Kathy McMorris Rogers, who was in the House last year, and put out a somewhat similar document looking at reforming the NIH. I think this is also an important document because it seems that a lot of the reorganization that's proposed in the skinny budget and the consolidation actually came out of this particular Energy and Commerce report from Congressperson McMorris Rogers. And what you can see in the current report that just came out is consolidation. So, for example, NIDDK, which looks at kidney research, is going to be consolidated into a Body Systems Institute with NHLBI and NIAMS. There'll be a Brain Institute, a Disability Institute, Behavioral Health, a General Medicine Institute. NCATS is going to move to another area, but is not going to be eliminated. National Cancer Institute, for example, stays on its own. And then there's eliminations. 4 institutes are being eliminated down in the bottom row, including Fogarty and the Nursing Institute. This is part of this overall skinny budget that has that sort of significant around 35% cut across the line. And I think I would sort of keep this in mind. Reorganization, I don't know what everybody on this call thinks. I think there may be something that's gained by reorganization, especially there could be something gained from discussing potential reorganization. I think the elimination is something that's going to be harder for the administration to necessarily accomplish. And could have much more severe consequences than reorganization that actually may be more conducive to research that spans disciplines. So when approaching this, I think we need to sort of learn and be aware of what is meant by the term discretionary spending. And the government has, you can broadly break things up into two buckets, this discretionary and non-discretionary spending. Non-discretionary spending is on things like entitlements, like Medicaid and Medicare and Social Security, and actually forms the vast majority of federal spending. Discretionary spending is on everything else. And NIH, for example, falls into discretionary spending. And discretionary spending occurs in two different ways. It occurs via authorization and appropriation. Authorization is the permission to act. So in this, committees in the House and the Senate authorize. They say that, hey, the NIDDK exists, and the NIDDK can be funded up to a certain level of money. The appropriators then come in and say, okay, we have this cap as to how much NIDDK can get, and we're going to fund the entirety of this, or we're going to fund 80% of this. So it selects how much of the authorized funds to provide. Importantly, you can't appropriate to something that's not authorized. So the Body Systems Institute isn't authorized. It doesn't exist yet. It could exist, but right now it doesn't exist, so it can't get appropriations. And the key thing about appropriations is it allows an agency to make binding commitments, so to enter into a contract or an agreement to spend funds. I think the last thing, and this is on the bottom, is you'll hear about reconciliation, and the quote unquote big beautiful bill is something that's looking at reconciliation. That applies to non-discretionary spending. It doesn't apply to discretionary spending. So for this discretionary spending, at least in the Senate, you need to have the ability to break a filibuster should that happen. And that's going to be a really important thing because the Senate is a 53-47 margin between Republicans and Democrats. And as we saw from Cassidy's priorities a few slides ago, as a Republican, and Susan Collins, who is a Republican, who's also has a very influential role here, this is much more balanced, I think, than it may appear right now. So what can we expect? This is a big question. I asked the magic 8 ball. It said hazy, try again later. So I tried again later, and this is what I came up with. I think that there's a reasonable likelihood that the budget process may not be completed by October 1st. That's the start of the 2026 fiscal year. If that's the case, I think there may be a continuing resolution at fiscal year 2025 levels for these areas of discretionary spending, because there is a lot to do when it comes to authorization in this particular process and then appropriation. I think there are the major NIH and other discretionary cuts likely require 60-cent votes, and those don't exist. When we look at specifics that we've seen dramatic proposals to cut overhead costs, so F&A. If I had to guess, I would say that this likely can be done without legislation. That's stated for contracts that are already signed, sealed, and delivered. Those probably cannot be broken, and the lawsuits are going to be successful there. But when these are reopened to negotiations, my guess is that overhead's going to go way down. I think also, as we've already seen, there's going to be a major focus area reprioritization. This is potentially, I think this is also probably legal, although it likely is not legal to not spend already appropriated funds. So they can shift funds, but they still need to fund the broad areas that have been authorized and appropriated. So to move on to the next area, I know this is a lot of talking, but we'll kind of go through this, is dialysis and the bundle and the prospective payment system. I think what you can see here is that, at least in the last 2 years, this system has been underfunded. There was this interesting bump in 2019 on the Medicare margin, it's Medicare fee-for-service margin, when calcimimetics entered the bundle, because calcitide costs were appropriated into this, but then everybody shifted to cinacalcet, for example. So we have a relatively underfunded dialysis system. The other big thing that's going on in the world of dialysis is we've seen a major change in the prevalence of Medicare Advantage as the dominant payer in this. So fee-for-service has gone down dramatically. Medicare Advantage has gone up. This is data through the end of 2023. But if we extend this to 2024 and 2025, Medicare Advantage certainly is more than 50% of all patients being paid based on dialysis provider data. And fee-for-service is far less now. And that's really important because fee-for-service was a single system with single data reporting, whereas Medicare Advantage across the country is hundreds and hundreds of different payers, each with their own nuances, rules, regulations, networks, so on and so forth. So what does this mean? I think the first thing this means is that Eugene Lin is going to have a very interesting talk in about an hour or two on this subject. But looking forwards, I think this really emphasizes that fee-for-service Medicare is much less important now than it was 5, 6, 7 years ago, when it was really the only show in town and the dominant payer. What this means is quality metrics, things like the quality incentive program, which is built on a fee-for-service environment, is really diminished in terms of importance. If you could take a 2% cut on 80% of your patients, that's huge. If you're taking a 2% penalty cut on 25% of your patients, that's not so much anymore. And it really de-emphasizes that quality program. There's going to be large data issues because reporting requirements for Medicare Advantage and the data available for Medicare Advantage plans is very different than the data available for Medicare fee-for-service. And even when looking at the USRDS, who honestly knows exactly what's going to happen to that as that is really administered through NIDDK. When it comes to the models through CMMI, these also currently only operate in the fee-for-service environment. You can have some tweaks and some nibbles, but these are largely fee-for-service. And this is going to make models much, much harder to run. And I think it was also a barrier in the KCC model, which we'll talk about because there were major changes in that just a day or two ago. We do continue to have issues with restrictive networks, and you can see that this is something that actually can be a huge issue when patients have access. And when you compound that on the Marietta decision with commercial insurance, you may have a lot more stresses being placed on dialysis organizations. And then innovation issues. Well, Medicare Advantage is required to adopt the same medications that Medicare fee-for-service is. If you have a new agent entering the dialysis system, they can certainly take their time about it, and you need to have separate negotiations with each MA provider rather than a single decision from Medicare fee-for-service and the government. So I think there's huge implications, but what I would predict is that there's not going to be any major policy changes with MA and the kidney space, at least in the next year or so. Looking a little bit more into the dialysis care in the bundle, I do want to just mention real quickly that we have two quality systems. There's the QIP, and then there's Dialysis Facility Care Compare, which is also called 5-Star, or Dialysis Facility Compare. These have a bunch of metrics. They have metrics that are the same. They have metrics that are different. They have some domains that are the same. Some domains are different. And some of the metrics even have different specifications, even if they're the same metric and in the same domain. This is very, very confusing and kind of baffles me. So my prediction here is that we're going to see consolidation of quality reporting systems. My guess is we'll still have a QIP and a dialysis facility compare, but I'm not 100% certain on that when we sort of look up in 2027. I think we're definitely going to have a reduction in the quality metrics that we're required to report on and that we are judged on. And I think that there are going to be attempts to incorporate Medicare data better into this quality reporting because Medicare Advantage data, because that's going to be the most common patients that we're seeing. This is the QIP for the current calendar year 2025, which means it's paid in 2027. And what you can see here is that there are 16 different quality metrics in the QIP. I highlighted 3 of them that are relatively new that are focused in on health equity. One of them is just an attestation that your dialysis facility is committed to health equity. The other 2 are more focused, and these look at screening for 5 health-related social needs off of a specific form largely. So this is the Accountable Health Communities form. And then the screen positive rate, where a dialysis facility has to report the proportion of patients who identify as having food insecurity, for example, or having housing instability. And remember, these are all publicly reported. I think everybody in this seminar can probably predict where this is going. And these are I mean, there's no way that these are going to stay in the QIP when we see the proposed rule coming out in about a month. What does that mean, though? I think all of us here, and I know ASN, we have as a goal a commitment to health equity. And if you think about health equity, that's the ability to raise people up so that their outcomes have the potential to be the same, regardless of their backgrounds, regardless of who they are, regardless of their education. And Deidre Cruz, who is the past president for ASN, actually wrote about this in an editorial in JAM in 2021 about the importance or the need to not necessarily conflate workforce DEI with the goal of equity in patient care and the health of surrounding communities. And I think this is actually going to be not necessarily where we are, but I think this is where we have to be as advocates for our patients going forward. So as we look at this, there's a tremendous role for advocacy. And I think we need to be circumspect in how we state this, where we focus in on health equity and we frame inclusivity and equity based upon wealth, urban versus rural status, so on and so forth, rather than elements that are being extracted from DEI. And I think it's really important as we advocate for patients and patient care and equity for our patients that we are able to differentiate workplace DEI from health equity and disparities efforts. How this is going to affect data collection and clinical care, I'm not sure. But as far as I can tell, we're still going to be allowed to collect these data if this is what we want to do. And critically, this comes out to research. And you can think of APOL1 in the kidney space as the prime example of a condition that may disproportionately affect a specific group, but where research and treatment of this is so critically important for the well-being of entire populations. So I think the end of DEI, and that is, I think, what we're seeing in the next year, it's incumbent on us to make sure that this is not the end of health equity. So to finish up with the ESRD PPS, the Prospective Payment System, this is the statement from the Medicare Payment Advisory Committee. And what this says is for calendar year 2026, the Congress should update the Medicare 2025 base rate by the amount determined under the current law. So basically, I think all that we're going to see is a simple inflation adjustment, which hopefully gets it correct. Although for the past several years, it has not gotten it correct. And we're not going to see any significant new money in the Medicare space. I don't think in the fee-for-service space, at least, we're going to see withdrawal of a lot of money either. I think we're going to kind of maintain the status quo. All right. In the last 5 minutes, we'll sort of talk about 2 or 3 other things. One is the kidney models and CMMI, and Kevin Erickson's going to talk about this moving forward in a later talk. But as everybody knows, there are 3 models currently running. One's IOTA, which is a mandatory model. One's ETC, which is a mandatory model. And then there's the Kidney Care Choices, which is the voluntary models. IOTA is interesting because even when there was a lot of discussion several months ago about canceling models and where things are going, IOTA actually still went forward. And I think that's important because it demonstrates a commitment to still exploring models that can provide healthcare. The government's goal likely is at lower cost with higher quality, or at least at lower cost, but balancing that forward. With the KCC, if anyone opened up the ASN in the loop this morning, they probably saw this. They're continuing for now, although the future is very uncertain given a loss to CMMI in 2023. Within the KCC, they're eliminating the KCF model. This was the one that was specifically focused on nephrologists. They're eliminating the transplant bonus. So that's the $15,000 bonus after 3 years for a patient in your model who gets successfully transplanted. I personally thought that was the most clever, creative, and the coolest part of these models. And one that probably takes many, many years to see a societal and financial benefit and probably could not be accounted for properly in the systems to measure loss or gain here. The other thing is the CKD quarterly capitated payment is going to be halved. So overall, these changes, and there's a 1% haircut here as well. So these changes overall actually make these models much less favorable, particularly for nephrologists. The ETC, ESRD treatment choices, is going to be canceled. And we'll learn more about that when the proposed rule comes out for dialysis in about a month. It'll either lose about 6 months or an entire year of the program, depending upon what they decide. And this was because they were unable to show a difference between treatment groups and non-treatment groups in the ETC. So this is where I see this going, and it'll be really interesting to see how the IOTA model takes off. Kind of the last thing I want to talk about, because this has a lot of news, is Medicare and Medicaid in 2025. And this is the quote unquote big, beautiful bill that I mentioned before. This is probably the most contentious issue before Congress, and it's non-discretionary spending. So it is subject to reconciliation, and things can be done here with a simple majority in the Senate. Sort of teasing out what's in there, it's about a $60 to $70 billion annual cut from Medicaid. There's going to be work requirements added for adults up to age 64 without disabilities. That shouldn't really impact dialysis patients, but may have really serious impacts on people with chronic kidney disease. One of the biggest things is the reduction of something called the FMAP. So this is the federal match, which with the ACA was raised to 90%, and is going to be reduced from 80% for states that provide coverage to immigrants who are not, quote unquote, a qualified alien. So this means that your payment for all patients, if you have these programs, is going to be reduced by a significant amount. Different states are going to have different ways to deal with this. There's going to be different strategies. Some will say, okay, then we're not going to do this at all. Others may try to find ways around this. And it's really too soon to tell what the effects are going to be by state. It could be possible that states are going to be able to steer people into private insurance. Maybe, maybe not. States may establish their own completely separate programs for people who are immigrants that are totally divorced from Medicaid. And that may be around some of this, but that would cost a lot of money. So there's a lot of different possibilities here. But you can see here, at least with this, that's going to have a dramatic effect on states that have expanded Medicaid to be able to cover these sort of emerging cases. And in Utah and Illinois in particular, there are trigger laws that could end ACA expansion altogether if the FMAP drops. So these could be fairly dramatic effects and have a really huge impact on nephrology care and hospitals and patients, particularly those who may be undocumented, who have health issues the same as everybody else. Focusing in on that same topic, and again, this is Dr. Crowley's going to talk about this a little bit later too. Workforce is another huge issue that's arising. As you can see here in nephrology, we are very dependent on an international workforce. I think there's a tremendous amount of uncertainty here, and we just don't know what's going to come. But if people are not coming to this country, I don't know where we're going to find our transplant nephrology workforce. I don't know where we're going to find our dialysis nurses or our patient care technicians. And that's not even to begin starting with nursing homes and hospitals. So another huge issue of uncertainty moving forwards. I'm going to skip through this. Just tariffs are very confusing and are changing by the day, as you can see from this headline from yesterday morning and yesterday evening. But one thing here is that the tariffs and the laws that we heard about yesterday being paused and then unpaused don't really affect what's going on in the pharmaceutical space in kidney, because it's using the Trade Expansion Act rather than IEPA in terms of tariffs. There was a request for commentary about this. We're really the concept that if medications are largely coming from certain countries, and these certain countries may not necessarily be allies, that this could be a national security threat to the United States. Hard to know what to make of this. My personal opinion really echoes the opinion of pharma in as much as we may identify countries on a list, but I don't think that large tariffs are going to go into place on medications. I just don't think that would be popular, and I don't think that would be a terribly effective process. Last but not least is drug pricing. And again, this is another huge area of uncertainty. This may not directly affect nephrology as much, but it certainly could affect the ability to obtain medications. Medicare drug negotiation will be ongoing. The 340B prescription drug program that's used to provide care at safety net hospitals and other hospitals that provide care to similar populations may be threatened. And there's going to be a move to combat anti-competitive behavior by manufacturers. So just to sort of finish up, and I think we really finish up with a time of uncertainty. When we talked about research earlier, we could talk a little bit about how, well, if I'm a clinical researcher, I can do drug trials instead with pharma. That actually may also be an area of uncertainty as the FDA becomes changed, and you're not able to talk to the FDA about, well, I need to do this or I need to do that, or other research becomes deprioritized somewhat suddenly. And it may make the United States a higher risk area to invest in for many of these international countries. So I think the conclusion here is that we really don't know what is going to happen. And the amount of uncertainty is tremendous, and it could be very impactful. I think we still have the 2019 executive order on kidney health, and that should be a continuous talking point for the nephrology community. We're going to see huge changes in research funding. I think if I had to bet, and that's probably a bad idea, I don't think we're going to see huge overall cuts in federal research funding, but I think we're going to see changes. I'm not sure what we're going to see in terms of imports and drug pricing. I think this could be all over the place and could change week to week. The Medicaid cuts are coming, and those are going to be highly impactful, and the workforce is very vulnerable. Ultimately, last but not least, we have an uncertain dialysis fiscal future, especially as Medicare Advantage becomes the primary payer. So thank you very much, and I think we have a couple minutes. I don't know what Sumit wants to do in terms of questions.
Thank you, Dan. That was wow, that was a whirlwind of a lot of information. So thank you for doing that. So I guess I'll get the questions started. If people have questions, please feel free to add them to the chat, or if you can raise your hand, we'll try to call on you, time permitting. So I guess we've all seen sort of the ups and downs with the tariffs and creating the uncertainty on the economic side. Do you think the uncertainty on the healthcare side, what is it going to do? Like, to us, the CKCC model has changed. We're worried about models being pulled or not implemented. And I know I get questions all the time about whether IOTA is going forward or not. Not that I know the answer, but the level of uncertainty sort of doesn't help, right?
Right. And I think IOTA is going forward. I think the cancellation of the ETC is actually probably a good thing. It was getting into its most punitive periods for the community and would have taken money out of kidney care. So I think that's a positive. But there's really just huge uncertainty. And that's the hardest thing to know about what's going forward. So that's what's rocking the markets. Every day you see these huge swings based upon one piece of news or another. And just hard to know what is going to happen going forwards. Tariffs and imports are a classic example of this, and we just don't know.
And what do you think of the most recent changes in CKCC? Thoughts?
I think so. CKCC has a critical variable in this. It's a voluntary model. I think with the 1% cut, I think with the loss of the transplant bonus, all the KCFs are done at the end of the year. And I personally see, with it being a voluntary model, many people deciding it's just not worth it to engage, particularly with a lot of the uncertainty that was present in terms of attribution of beneficiaries to the model, as well as what sort of your cost basis was, so your expected costs over time, where it was really uncertain what you were being compared to in terms of, are you saving money or not? And that would be corrected retroactively. So I think people are going to get out of the voluntary models, if I had to guess.
Okay. Well, thank you for that.